Hello everyone. Stratasys D2M Solutions and 3D Life would like to thank you for joining today's webinar, Improving Delivery of Healthcare with 3D Printing. By the end of it, we hope that you will become familiar with the latest 3D printing technology offerings from Stratasys, the medical applications where our systems fit to, and finally have an idea of how hospitals and medical institutions can leverage 3D printing for the benefit of their patients, as well as for the benefit of innovators and researchers within hospital institutions. My name is Aris Petridis from D2M Solutions, and towards the end of my presentation, I will turn the controls over to Dr. George Sarris of 3D Life. He has a very interesting presentation to show you. He will be discussing how he has been using 3D printing to enhance the delivery of healthcare to patients under his care in Athens, Greece. Through his personal experiences in using 3D printing, Dr. Sarris saw the need to share his expertise with other surgeons and has established an expert team who can provide essential 3D printed medical models as a service to the medical community. Throughout today's webinar, please type any questions that you might have, and we will make sure to answer them on a one-to-one basis during the following days. So as we progress through our agenda today, we're going to start by investigating how the 3D printing process works, and then look through how hospitals can leverage this technology to improve the delivery of healthcare in patient care, in clinical training and education, in lab and operating room efficiency, and finally in hospital innovation. So before we kickstart with our agenda, let me give you a very brief introduction about D2M Solutions. We have been based in Dubai for the past almost 6 years now, and our company provides complete end-to-end product development solutions, all the way from conceptual design down to the final manufacturing of products. We offer a very diverse product portfolio that we tailor into packages and solutions so as to specifically meet and suit what the company wants to accomplish. Our solutions include software and hardware for reverse engineering and quality control, as well as software for computer-aided design, manufacturing, engineering, and medical image processing. And finally, we provide industrial high-performance 3D printers to manufacture the final output with a choice of different thermoplastics and resins that have been developed based on specific industry needs, whether it be the aerospace and defense, or the automotive, or the medical. So ultimately, what we strive to do is to improve and optimize the design to manufacturing process, reduce costs whenever that is possible, and at the same time give unlimited design freedom to engineers to unleash their full potential. And this is because 3D printing really gives you the ability to think and develop products and parts that otherwise would be impossible with traditional manufacturing processes. So we are the gold reseller of Stratasys 3D printers. We cover the entire Middle East region along with some other countries in North Africa. Our headquarters is in Dubai, and we have strategic reseller partnerships in Greece, in Pakistan, in Saudi Arabia, so that to ensure fast and efficient region-wide support for our customers. So moving along on our agenda, we will take a look at who Stratasys is today, and then look at some 3D printing terminologies that may be useful for those who are not really acquainted with 3D printing or its processes yet. So Stratasys is the leading provider of 3D printing solutions with the largest installed base of 3D printers. We have over 50% of market share in industrial units sold, and over a third of the desktop units sold in 2014. Stratasys is the combination of not only Stratasys and Object Geometries, the merger that happened in 2012, but it's also a combination of MakerBot since 2013. And in 2014, Stratasys acquired and integrated with Harvest Technologies, Solid Concepts, and GrabCAD. So what is 3D printing? It's a process of creating physical objects directly from 3D data, usually from one layer at a time, starting from the bottom and moving up. You may also hear people refer to it as additive manufacturing to describe the same exact process of this additive creation layer by layer. And the term additive is simply used because we add material whenever needed instead of subtracting, as you would encounter in a typical manufacturing process. So there are 3 steps. The first, during pre-processing, is to export your CAD data into the STL format and use the printer software to calculate the placement of material. During production and printing, the system will lay fine layers of material to build the part from the bottom up, one cross-section at a time, until the final product is achieved. Once the part has been fabricated, the final step is to remove the support material, either manually or by just dropping the parts into a bath of detergent, if you are, of course, to use a water-soluble support material. In medical, if I was to summarize, let's say, the workflow, we start with a CT or an MRI or a 3D ultrasound. We then use the Mimic software for the segmentation of 3D medical images. We create accurate 3D patient-specific models. And finally, we 3D print them with Stratasys technologies for a variety of different applications and uses. So, focusing now on what we've learned from our customers who have taken Stratasys' capabilities and added the next level of capability, let's examine why would we utilize 3D printing in the medical industry. And in fact, we have to look first at what is happening and what are the challenges that are facing healthcare. We already know that healthcare is rising in cost, and in the vast majority of countries, in over 95% of them, medical spending is, growing faster than inflation. Patients are focused more and more on understanding what clinical decisions are being made, simply because they're being asked to share more and more of the cost. The aging population and resource constraints are in opposition to this trend and really have to drive us towards creative solutions. Finally, payers are focusing on outcomes. It's not only the economics, but it's what it is wasteful, what are the unplanned readmissions that can result in reimbursement penalties, and how do we think about improving outcomes so that the patients are treated right from the very first time. So as an example here in this chart, in the US, healthcare spending is forecast to grow 4 to 6% per year and is expected to account for at least 19% of the US GDP by 2023. So, and again, as patients are taking on greater share of the cost every day and what clinical decision making happens, and this is a result of the rise of information access to everyone. So, as we look at that, we have seen our hospital customers utilize 3D printing to improve patient care across the spectrum of outcomes and economics. And that medical value chain starts with hospital innovators that think about what is the next generation of products that they want to provide to the patients, to the people that they are delivering care to every day, and that starts with rapid prototyping. It might also include jigs, fixtures, and even production parts to enable labs to operate more efficiently. It can go even into realistic training and education models to quickly evolve the skill sets of physicians that are learning, but also for very skilled physicians who have to undertake continuing medical education throughout their careers. Finally, we have seen our customers utilize our solutions to really change how they communicate with their patients, how they prepare for surgeries, and ultimately how they affect the overall patient care. So let us now walk through some examples of each of those elements in the value chain to see how Stratasys' 3D printing solutions are really here to improve the healthcare delivery. So the first area we'll discuss is patient care, and the area that we are focused on is achieving better outcomes. Is for us to be able to take patient-specific images, make customized medical models for the physicians to be able to do pre-surgical planning, as well as get a tactile feel of the patient's actual pathology. Now, in terms of the surgical preparation, it's utilizing these models based on that specific patient anatomy to optimize the approach. It utilizes the material properties to simulate live tissue characteristics, get an unobstructed view like you would get through imaging, but not with the physiological tissue, and then gain those physical, those spatial and tactile benefits that a computer model that is projected on a 2D screen cannot match. Example of how physicians at a major hospital in Miami are using patient-specific models for a very challenging structural heart disease case involving a little girl, Mia.
Mia was born with an abnormal aortic arch. It's a rare problem. We see it a lot. It frequently gets misdiagnosed.
This was a child that had been having problems with breathing and swallowing for a long time. No one had quite come up with a diagnosis.
Because it mimics asthma so much, I think that it often goes misdiagnosed.
So Mia lucked out. She had a really good doctor who said, I think this is great.
So when we were able to make the diagnosis of a double aortic arch, it was very satisfying.
So then the challenge is a surgical one. How do you divide this double aortic arch and save her life without hurting her?
At this children's hospital, we're actually using 3D printing to assist the surgeons with their surgical planning and teaching of new medical students. So having the ability to make these 3D models, to look at them on the screen, but also to print them out and hold them in our hands, has really made a fundamental change in how we view a lot of these diseases.
Make a 3D model of her very complex aortic arch vessels. We were able to figure out which part of her arch should be divided to achieve the best physiologic result. I showed the family their daughter's heart. I got the textbook saying this isn't really your baby's heart, but it kind of looks like it. Here's how we're going to do the operation. That doesn't resonate with them. I showed it to them. I said, this is what's choking your baby. This is why she's taking all those medications and why they won't work. It's very powerful when you show a family, this is your baby's heart, and this is how I'm going to repair it.
Like using a model, you can see how it just does seem simplistic. We were very nervous before we met Dr. Berkeley. Anytime there's any kind of surgery associated with the heart, honestly, we were terrified. So the fact that the 3D modeling, it just made us feel so much more comfortable with the process.
They could feel confident that we were going to do the right thing. When we did the operation, we took intraoperative images, and they look exactly like that look.
From having 4.5 years of not knowing to all of a sudden in less than a 2-month time frame, she's back out of her surgery, back to normal. So that's been a great experience for us. She's very active. She loves dancing. She loves baseball. She likes doing everything. So now it's just going back to normal life and not being worried.
Show them the level of sophistication that you have. Show them what you're capable of. The 3D printed heart, accurate to the most minute detail, has been the difference maker for me. It's helped me take somebody from being inoperable to operable, and we've saved their life.
Is really a tool for physicians seeking to optimize patient care, and additionally it can really differentiate your hospital from others in the region by being able to showcase both innovation and technology adoption. And of course it will bolster your leadership in patient care by providing truly personalized therapy for complex procedures with patient-specific printed models that can really increase the chances of success. So another very exciting part of driving innovation and adoption across hospitals is in research and educational institutions. The question is, how do we train the next generation of physicians and also at the same time allow these hospitals to do continuing medical education throughout the physician's career? So this is a clinical training with 3D printed models that has very few limitations. And if we take a look at the challenges of today, first we have that animal anatomy only approximates human anatomy and may not include, of course, the relevant pathology. Cadavers are very highly processed and don't retain a very live tissue feel, in addition to not having the pathology of interest. And of course, both of these need to be worked on a very controlled environment. And finally, mannequins merely approximate the average human anatomy and complexity. So as we look across all three of these, 3D printing has been used to make very high impact, clinically relevant training models. So these parts are fabricated from non-invasive studies of the human anatomy that are done via CT scanning, MRIs, 3D ultrasounds, and then allow hospitals to customize. It allows them to enhance and improve the overall realism of their models that are utilized in the education and on the ongoing education of their physicians. So you don't really need any specialized facilities, but yet you can replicate all of those complexities, but more importantly, replicate the medical pathologies of patients by using 3D printed medical tools and guides. So another great example of this application is a case study from the Center of Biomedical Technology and Integration in Malaysia. They have been utilizing Stratasys technologies to take a patient-specific case and develop a curriculum and model for training physicians on neurosurgery and specifically image-guided neurosurgery. Now, traditionally, training physicians in a complex high-risk procedure such as this is an apprenticeship model in which the trainee watches an expert perform these procedures and gets only the opportunity to perform only a portion of the total procedure. And of course, it could take many procedures until a trainee has completed all of the individual steps, let alone completing an entire procedure from beginning to end. So using this sophisticated multi-material and multicolor model, the trainees can now perform the entire procedure in a zero-risk environment and develop the skills they need faster and more effectively as they get involved in all necessary steps on one go. So, as I said, this is a case study from the Center of Biomedical Technology and Integration in Malaysia, where they have utilized printing technologies to take very patient-specific cases on how to train physicians on image-guided neurosurgery. So as you watch the clinician, they cannot only open up the skin, but they can also use a bone trephine to be able to prepare for the insertion of a navigation telescope and endoscope into the brain. Of course, the clinician is going to utilize the natural pathways in the brain, the ventricles, to begin to extend further and deeper into the brain. So we start seeing red arteries, we start seeing blue veins. And as we progress deeper into the brain, this is the areas where we can see filled with fluid, mimicking the cerebrospinal fluid of the brain. Here we see a perforation of one of the floors of the ventricles using a pair of forceps. And as we move deeper into the brain, we can begin to see the rising of major arterial blood supply, which is color encoded in red, rising from the neck region up. So what is important as they are training physicians is to show what could be a complication of a biopsy of a tumor in the brain. One of the challenges might be a hemorrhage, a bleed from the arterial blood supply that might be underneath the tumor. So by using this way, we can actually teach physicians in a very simple and educational step how to clear that field of U3 irrigation and control the hemorrhage through intracranial pressure. So by using Stratasys' 3D printing solutions, the next generation of physicians will be able to be better prepared for the patient care challenges of the future. So now moving into the lab and operating room efficiency, every hospital, operating room, and research lab has its own unique requirements, of course. And it's very usual that off-the-shelf products are not always sufficient, 100%. So 3D printing, again, comes into play. It can empower the hospital to create custom solutions to meet exactly those unique needs. So as physicians think about, or even medical device companies or medical pharmaceutical companies think about bringing new products to the market, these are rapidly designed, developed, and printed tools, jigs, and fixtures. They can be built on site very, very quickly, 90% faster than with traditional manufacturing processes. In other words, in 10% of the time, and with less than 30 to 50% of the cost. These parts can be held as digital inventory and reutilized over and over again using biocompatible materials and certified materials that are sterilizable to allow those parts to intersect with other products that will be used to treat patients in the surgical room. So 3D printing is really a very versatile tool that can introduce efficiency, it can introduce cost and time savings into many, many processes. So looking now into hospital innovation, 3D printing has been widely adopted as a tool to unlock innovation across all industries. And bringing this capability to the hospital will enable your physicians to translate their genius into something that has a physical form. So who are these innovators within hospitals? These are the physicians who are every day touching patients, are dealing with patients, are treating patients, and really intersecting with real-world problems. What we can do is accelerate their time to verification and validation. That might be in conjunction with major medical solution companies, or could also be driven as innovators within hospital environments that think about new ways of treating their own patients. And this is rapid prototyping. So physician insight into the medical care is a great resource for new products and solutions. And that's why 3D printing is the key to unlock that potential. So D2M and Stratasys provide a very wide range of 3D printing solutions with easy operation, a very simple workflow, and we have the widest range of material options anywhere, which really makes us the clear choice for on-site 3D printing. So as we look across our solutions, we provide systems running on FDM technology, which uses production-grade thermoplastics to make strong and durable parts. On the other hand, we also have PolyJet, which produces detailed parts with very fine layer resolution. And for example, our flagship system, the J750, which offers multicolor and multi-material 3D printing parts, is based on that PolyJet technology, and along with the Connex 3 system are the ideal solutions for hospital environments. So when it comes to material options, Stratasys really has thousands of materials to choose from to fit the exact needs of your application. For the medical sector, that includes materials that can mimic both soft tissue and hard bone within a single print, materials that are biocompatible, that are sterilizable and can be brought into the patient operating environment, and that are production-grade thermoplastics with very high performance characteristics. But it's not only the 3D printers, which are the systems and the materials available, that gives us the ability to create and simplify the workflow in the widest range of material options. We have also set up Paradigm 3D, which is the first digital factory of the future in the Middle East, and is dedicated to supplying 3D printing services for low volume and customized production, as well as services for one-off parts for the medical industry that could be used as training models or even as surgical guides. So in summary, hopefully I've given you the chance to see Stratasys' technology and the ways our customers are driving hospital innovation from the generation, from the validation, verification of ideas, all the way through improving physician training, and ultimately how they impact the delivery care to their patients. So now I would like to handle the controls over to Dr. Sarris, who is the director of the Athens Heart Surgery Institute. He is the chair of the Department of Pediatric and Congenital Heart Surgery at major Greek hospitals in Athens. And he's also the CEO of 3D Life, a company providing 3D printing services in the medical sector. He will give you his side of the story, how he has been using 3D printing for the past years, and what his company was able to accomplish. Dr. Sarris?
Hello from Athens. Can you hear me?
Yes, we can, Dr. Sarris.
Terrific. Well, I enjoyed your presentation, Aris. It provided a very nice overview. What I will provide in the next few minutes will be our experience with 3D printing and its applications in complex cardiac surgery, especially pediatric heart surgery, and how we came about being involved in this project. Let's see, how do we... This is a photograph from a specialty newspaper, Thoracic Surgery News, which is a publication of the American Association for Thoracic Surgery, and it's from last year's annual meeting, which took place in Seattle, Washington. And you can see on the front page there's a photograph of some 3D vascular models with the impressive title, 3D printing is poised to transform cardiothoracic surgery. And I think that this statement is very, very accurate. Just briefly, I can tell you that I'm a heart surgeon. I studied medicine in the United States and trained in adult and then pediatric cardiac surgery. I have been involved for several years with operating on children with complex heart disease in the United States and also in Athens, Greece, where I have set up a number of pediatric heart surgery programs. And we always try to provide better services for our patients, while at the same time being faced with more and more complex problems as a tertiary care facility. So what is it that first attracted me to investigate the use of 3D printing? Well, it started a few years ago when I saw in my office the parents of a little girl, and of course the little girl, with a complex congenital heart defect, who had been operated on without resolution of the problem at a major international medical center. The surgeon was a very respected and very experienced colleague who was forced to, after opening the patient, stopping the heart and looking inside, to close without providing a medical solution. So this little girl had open heart surgery and nothing happened. Why? Because the very experienced surgeon discovered unexpected, complicated anatomy which had not been demonstrated adequately by the various preoperative imaging studies. Well, during a cardiac operation, the heart is stopped and opened. The heart muscle is protected by various means, but there is only very limited time during which one can safely operate. So the surgeon was under pressure, found a complicated anatomical situation. It was not possible for him, and I think for anyone, to devise a satisfactory solution. So the wise choice was made to back out and complete the operation without solving the problem. What he did, however, which was very wise, was to write a very detailed description of the anatomic findings. And this written detailed description was the basis for us to then be able to think in our head what we could possibly do, come up with a plan, which eventually, after thinking about it, drawing it out, and really agonizing about it, then eventually we did the reoperation on the child, and this was very successful. The question, however, raised in my mind was, well, is there a better, more realistic way to experience what is inside the heart than is possible with modern imaging studies, so that we would not be in a situation of unexpected findings and pressure of time. And of course, myself and many other colleagues have been in similar situations, not rarely. And of course, we know that architects build architectural models, and they can appreciate better what the three-dimensional structure of the house they are planning to build is, and their client can see what it is and think of modifications. then I realized in looking into this that dentists were fairly advanced in creating models, initially I guess analog models, but indeed very helpful for them. And the question was, well, can we do this for the heart? The heart has very special features that set it apart from different organs and tissues. Its image density is similar to blood and to surrounding tissues, unlike, for example, bone, which has a very distinct signature, let's so to say, in imaging studies. The heart moves and very rapidly during the cardiac cycle, especially in children. The heart rate is high, and that creates additional difficulties in getting a still image on which to base further processing, and also really very great accuracy is required. Now, as already described, I think, by Peter, traditional creation of 3D structures, models, involves removing material, and we're very familiar with sculpture, which has been used since antiquity to create beautiful art. And in modern manufacturing, we have turning or milling, whereby machines can remove material from a slab of metal or other materials to create a desired part. But as described previously by Aris, in 3D printing, we actually add layer by layer material, and the 3D model is an example of additive manufacturing. Now, in cardiac surgery, when we use 3D printing, we view this as a logical evolution from the early days of anatomical studies pioneered by Andreas Vesalius. We then moved to a two-dimensional image of the human body or part, such as a chest X-ray film. Then science progressed to a CT scan image or a magnetic resonance image, where we see slices of the anatomy, and further it became possible to create virtual 3D images on computer screen. But I'll tell you that there is a huge difference between seeing a 3D representation of a structure based on a CT on the computer screen to actually holding in your hand the physical model of the pathology, as you see here on the right side. So, in order to create a 3D model of the heart, we need to base this process on some applicable imaging modality which provides 3D data. And normally we would use a computerized tomography scan, which for our purposes needs to be enhanced with intravenous contrast in order to delineate the differences between the blood volume in the heart or the blood vessels and the surrounding tissues. Similarly, a magnetic resonance imaging scan also needs to be enhanced with intravenous contrast for cardiac applications. And other possibilities include 3D echocardiograms and rotational angiograms, which can be obtained in modern angiography by modern angiographic machines. The workflow, as described previously, starts first of all by identifying the clinical need. Everything starts when a physician is faced with a clinical problem which requires further investigation or greater understanding in order to do the subsequent necessary steps. So that then leads to deciding which imaging study will be obtained, and that must be obtained under particular conditions and following particular protocols. Then the following would involve analysis of the images, focusing on the area in question, segmenting out, taking out of the total information in the medical imaging study, taking out the information necessary to create a virtual 3D model. At this point, I think it is very important for the physician ordering the study, or the medical team, to have very close communication with the engineers involved in the project, because it is necessary to make sure that the requirements of the medical team are appropriately imaged, segmented, and processed so that the end result will be truly accurate and useful. The next steps are more, they flow much faster, which should be a conversion of the medical image data, the DICOM data, to the STL form, which can be, so to speak, understood by the 3D printer, and the 3D model is then created. So here is an example of a CT scan, which is being obtained by utilizing intravenous contrast. So the IV contrast highlights the blood volume, and so we see the blood inside the left ventricle and the aorta. One can see the aortic valve, and we have various, it is possible to have various views of this and hone in the area, on the areas of interest. Then the segmentation procedure isolates the structures that we're interested in. We don't need to print the ribs, for example, in this particular, in some application we might, but in this particular case, we did not need to print the ribs or the lungs, so these can be isolated, and then the final virtual 3D model is converted into the physical 3D model, a photograph of which is here. So when I was researching the subject, trying to think of how we would be able to, in actual practice, have these three models, of course, found initially the history of 3D printing, discovered that there were applications for years in architecture, engineering, and industry, also applications in other specialties, usually involving bony structures, however. And after discussions in meetings and with colleagues who were also experimentally involved, we eventually formed 3D Life, which we launched last year, having assembled a large team of experts and obtained all the necessary ingredients, which involved identifying appropriate technology-specific protocols for proper image acquisition. It is very important that the images on which our models are based are usable and such that we can extract the greatest amount of information possible. We needed to identify appropriate software to segment the images, to obtain appropriate high resolution 3D printers, and of course appropriate materials, and we have been able to find such solutions with Stratasys. So now I'm going to give you just a few examples of how 3D printing, which we started using in our clinical practice for now over a year has really helped us achieve better results. Here is a case of a 26-year-old with increasing severe cyanosis, which means cyanosis essentially means that the amount of oxygen in the blood is lower than normal and the hemoglobin is not fully saturated. And this was due to a severe congenital heart defect known as double outlet right ventricle. Now, this is a complex condition. It is very difficult to explain this to non-trained physicians in this field. However, in simple terms, what that means is that both great arteries, which normally arise from the heart, the aorta and the pulmonary artery, arise from the right ventricle, from which only the pulmonary artery is supposed to arise. Now, in this complex condition, there are two different possible repairs theoretically. One would be an anatomic repair in which both ventricles are utilized in the way they function in a normal individual. And the other possible theoretical solution is a Fontan pathway in which both ventricles are utilized side by side, and there is no ventricle supporting the pulmonary circulation. Now, this is a very big difference. There is a very big difference between the two strategies with different outcomes and different pros and cons. And it would be natural for the patient to want to know which of the two can be applied, and for us to know which we should be betting on. It would be rather difficult to be forced to make this decision in the operating room. However, the complexity of the lesion was such that this patient could not get an answer from various medical institutions as to what would be the solution for her. And in fact, I think with good reason, because based on the imaging studies, it was not possible to decide what would be feasible in the operating room. So this patient was told time and time again, all right, you're going to have heart surgery, we'll stop your heart, we'll open it, take a look inside, and then we decide. And so you won't know until you wake up what we have done. And for example, one way might involve the risk of a permanent pacemaker and multiple reoperations. The other pathway might involve the need to take blood thinning medications for life. So these are very serious possible accompaniments of each strategy, and it was in everyone's interest to find out ahead of time what would be done. So we thought of perhaps trying to solve this problem by creating a 3D model of the heart. And these are photographs of this actual 3D model. I can tell you that when holding these models in my hand, it was possible within less than 5 minutes to realize what was feasible and what was not feasible, and therefore create the appropriate surgical plan, which was the Fontan operation. So this was was quite remarkable and really gave us impetus to proceed along and apply this methodology to more and more patients. Here is another example. There is a condition known as anomalous origin of the coronary artery from the aorta. This condition is responsible for many sudden deaths of young athletes and young individuals during exercise. You've all probably heard in the news that such and such soccer player dropped dead while playing soccer in the middle of an important tournament. And the second most important or the most frequent cause of such a tragic event is the presence of this coronary anomaly. The problem is that this coronary anomaly may exist in some individuals, and yet they are not, these individuals are not subject to the same risk. The risk is present when there is the potential for compression of the anomalous coronary artery by the surrounding tissue. And in this particular young boy, we could not decide, based on examination of the images of high-resolution contrast-enhanced CT, as to whether there could be compression of the artery, and if there were compression, how much did we need to move the surrounding structures to alleviate the compression. So we created this 3D model. We could hold it in our hands. This shows the anomalous, I don't know, can you see the arrow on my screen?
We can, Dr. Sarris.
You can, okay. So my pointer points to the anomalous artery, which courses between the pulmonary artery in white and the aorta in red. And this is another view of the same physical model. And it was possible just by deforming this physical model, which was created by a pliable material approximating the pliability of tissue. It was possible to demonstrate that movement by only a millimeter or two was sufficient to compress this coronary artery. The solution to this problem involves an operation whereby this pulmonary artery has to be moved into a position over to the left. This would be the patient's left. And we could, by manipulating this physical model, know exactly how much we had to do this at the time of surgery. This is now another case of a similar problem, and once again there was significant disagreement between medical experts as to whether the coronary artery shown here, originating in a slightly off position from the aorta, could be the subject of compression. And once we created this physical model, then we could demonstrate that yes, indeed, the origin of the coronary artery was subject to compression, and therefore this patient needs to have a corrective operation, or else to be permanently and for life excluded from sport. There are many, many examples. This is an even more complex situation of a cardiac defect known as pulmonary atresia with hypoplastic pulmonary arteries and major aortopulmonary collateral arteries. These are very difficult problems requiring a series of cardiac operations to be fixed. And in this condition, understanding the 3D geometry of the so-called collateral arteries, these are arteries originating from the aorta and supplying the lungs, and are entirely anomalous. They are not present in normal individuals. So for this condition, we, as I mentioned, need to perform a series of operations to bring the problem to solution. And after every step, it is important to understand the three-dimension configuration of everything involved. This is a model of the heart, the aorta, and the pulmonary vasculature of this patient after we have performed an initial operation called the aortopulmonary shunting. And in this model, we can demonstrate the artificial shunt that we created. You can see that here there should have been a large artery as large as the aorta called the pulmonary artery, but there isn't. There are all these anomalous vessels, and what we have done is we have created this bridge in order to help these vessels develop. So based on this model, which we then have the opportunity to study in our hands, we can turn it around, look at the back, identify where the anomalous aortopulmonary collateral arteries are, so that our intervention and our second stage operation can be precisely focused on the target. Here is another example of preoperative assessment. This is a case of a young woman who had had heart surgery several times before in order to address a congenital heart defect. And before a planned reoperation to replace one of her heart valves, we identified on her imaging studies that she suffered from a condition called a pseudoaneurysm. That is best described as a bubble coming off one of the vascular structures of very, very thin wall, which is liable to rupture. Now, what was difficult about this was that the pseudoaneurysm was very, very closely related to the sternum. And the sternum, which is the breastbone, is what we have to open in order to get access to the heart and fix the problem. This creates a very serious potential situation where, in opening the sternum, the pseudoaneurysm can rupture with the immediate catastrophic consequence of exsanguination of the patient and immediate loss of life. So it was absolutely necessary that we perform this operation with great accuracy to avoid rupturing the pseudoaneurysm. We therefore created a 3D model, and in this case we printed not only the patient's heart, but also, as you see here in white, the sternum. And we could turn this model around in our hand, look at it from every angle, and could demonstrate that this bubble, which is the pseudoaneurysm, was closely adherent and in fact growing into the sternum. So we therefore were able to devise a line of division of the sternum which would miss the pseudoaneurysm, and we did that quite successfully and were able to perform this operation, opening the patient's sternum, missing the pseudoaneurysm by approximately 2 millimeters, precisely as the 3D model had enabled us to design. And so this patient had very successful operation, and with her permission, she is being photographed here with myself and Lefteris Potopoulos, one of our surgical colleagues, proudly holding in her hand what really helped us to operate on her with much greater safety. You can see here the very close approximation of the pseudoaneurysm of this bubble, which is quite large and extends quite a lot towards the left. with a sternum. So I could go on and on. Here is an example of complex aortic valve disease with an ascending aortic aneurysm, which is a large dilatation of the aorta, liable to rupture, and a very complex obstruction of the aortic arch. And this particular model also helped us design this rather drastic operation necessary. So yes, indeed, to go back to my first slide, 3D printing is not only poised to transform cardiothoracic surgery, but it is transforming cardiothoracic surgery, certainly in our practice, and I am sure in the practices of many colleagues around the world. I should say that we've entered our 3D printing project for complex heart conditions, mostly pediatric congenital heart disease, to an medical innovation challenge by the American Medical Association. And the crowd voting segment of this competition ended just a couple of days ago, and I should say that of the many, I think more than 100 proposals of very ingenious innovations in medicine, the preference of the voting public, which consisted of physicians, healthcare technologists, hospitals, and but also patients. Our project was first in preference. I should say that although I'm a heart surgeon and I use these models for heart surgery, but this technology can be used by interventional cardiologists to plan and design implants, especially if they are custom made, and fitting can be assured in pre-intervention dry runs. And here's an example. Here's already a publication which takes a look at what is called right ventricular outflow tract morphology, which is the end of the right ventricle and the pulmonary artery, which can be deformed in various conditions. And therefore casts or 3D printed models can be created, and in here interventional cardiologists can apply stents, which they have the opportunity to measure, pre-measure, prefabricate, and try out before implantation into patients. I should say that seeing the tremendous usefulness of this technology in our specialty, I am sure that other specialties can benefit. We have seen publications and also on the internet many such applications, and certainly 3D Life offers its services to other medical specialties, including pediatric orthopedics, plastic and reconstructive surgery, maxillofacial surgery, neurosurgery, and oncologic surgery. Here is an example of a patient, a 1-year-old, who for a number of reasons had developed severe obstruction of the trachea right beneath the larynx, and that precluded endotracheal intubation so that anesthesia could be administered for the various operations required by the child. And it was very difficult for the anesthesiologist to do anything. The ENT surgeons were not sure how to approach it. This patient was offered a tracheostomy, which means an opening to be made in the trachea into which a artificial tube would be inserted so that access to the lungs could be provided for the operations to be done. And of course, a tracheotomy is a very, very difficult thing for a baby to have. It would have to stay there for over a year. Taking care of a tracheostomy at home is a major challenge, and removing the tracheostomy would leave the risk for stenosis and further surgery needed down the road. We approach this problem by obtaining high-resolution images of the airway, creating these physical models of the trachea, and they demonstrated the anatomic abnormality, which was tremendously helpful to the anesthesiologists who were able to intubate the patient who had the required operations without the need for tracheostomy. And I would like, having completed this segment of clinical applications, to also say a few words about surgical education. Utilizing this technology, it is possible to create libraries of various anatomical entities, especially the ones that are rare, and therefore they can be studied at any time without having to identify a patient with a pathology in order to understand this pathology. The 3D model created by converting medical images of a particular condition to a physical object can be studied by the team taking care of a patient and have a model of this particular patient's condition rather than the condition of a similar patient. And the even more exciting prospect is that of surgical simulation. Now, we know that simulators exist for various complex human activities. One very well known to the public is flight simulation. Pilots who transport you to London or New York or wherever, before flying you their 747, they have practiced and landed and crash landed this plane at zero risk on simulators many, many times. However, medicine still remains possibly the only high-stakes industry in which practice prior to game time is not routine. And if you think about it, in a rare and complex condition, as I think Aris Petridis really very clearly stated in his presentation, experience is obtained by the apprenticeship model, where a younger surgeon over a long period of time takes part assisting or doing initially a small and eventually a larger or all of the operation before he feels confident to do this independently. But for a rare condition, this can take time. And this practice is practiced on a patient. However, with 3D printed models of complex pathology, that can become very routine. So, for example, here we have a 3D printed model of a very complex congenital heart defect, which is known as hypoplastic left heart syndrome. This is an operation which is so complex that if one looks at the mortality of this operation, on average, in European pediatric heart centers, it ranges from 50 to 80%. The average is probably somewhere around 70% survival. So the mortality is 20 to 30 or 40%. So that's a very complex operation. Clearly, the most experienced surgeon in any team will do this operation, and the younger surgeons will learn how to do this by observing and helping, and gradually, if enough cases are available, doing more of these operations. The subject, of course, is always a real patient. However, once we have images of such a rare condition, and we produce a 3D printed model, then we can reproduce this in an unlimited way and organize teaching simulation seminars where this operation can be practiced at zero risk. And here are photographs of such a seminar where one can see this yellow material is a patch made of pericardium, which is sutured in the appropriate way in a simulation training module. And then what one can do is one can take down the repair and see what the actual patch, which was applied to repair this condition, looks like. One message from this was that the patch was not a simple shape. It was created by tailoring it along the way, but it is much better to know what the final shape is ahead of time while you trim and formulate the patch as you go. And you cannot do this in any other way than by doing the operation in a model, in a simulation model, and then taking it down and looking at the patch. You cannot do this, of course, in a patient. We have already, we're already planning a series of advanced international postgraduate surgical teaching seminars involving these conditions, and they will be unfolding over the next year. And also, we have launched a multi-institutional study, a cooperative study of 3D printing and its usefulness in the surgical or interventional management of complex congenital heart disease. And we're doing this in collaboration with the European Congenital Heart Surgeons Association and the Association for Pediatric and Congenital Cardiology in Europe. So just to highlight some of the current limitations of this technology, we do need high resolution image data with appropriate contrast. 3D echo is still of limited use. Valves still remain difficult to visualize and print. Segmentation continues to be labor intensive. Therefore, the process is time consuming, but it is improving. And of course, research in implantable biomaterials continues, and I am sure that they will continue to improve. So, in summary, we can say that cardiac 3D printing takes us, allows us to move from cyber virtuality to physical reality, enabling precise understanding of complex anatomy, planning an optimal procedure, simulating an optimal procedure, tailoring of needed parts such as conduits and so forth in advance, avoiding unexpected, unpleasant, and really unsafe discoveries at the time of open heart surgery, therefore permitting a safer procedure with reduced time, more precise application of what the plan is, and leading to a better outcome. Also, there are opportunities for medical education as libraries of models of pathological conditions can be created. The digital libraries can be there and models printed as necessary. Surgical education is, I think, seeing a window to the future. Simulation will be, I am sure, a very critically important part of medical education in medical schools and surgical education in surgical training programs. And we should not forget the value of patient and family education. When a patient and or the family hold a 3D printed model, the surgeon, believe me, is able very quickly to make them understand what the problem is, and therefore have the family as closer partners in a very complex and important endeavor. And to finish, a friend of mine involved in 3D printing told me this: a good image saves 1,000 words, a good model saves 1,000 images, so a good model saves 1,000,000 words. The future will involve bioprinting, which means printing custom-made, not only biocompatible, but eventually live tissues and organs. But I think this will have to be the subject of future seminars as research in this field is evolving and evolving rapidly. Thank you very much.
Aris?
Thank you, Dr. Sarris. That was quite amazing. It really showed how 3D printing with Stratus has, you know, saved lives, and I'm sure it will continue to do so. Congratulations for your work to you and your team. I have to say that it's certainly satisfying to say the least, seeing how, you know, our technology has made such a difference in medicine and, you know, generally in people's lives. So at this point, I would like to thank everyone who attended the webinar. We hope you really found it useful and really educating. At least I found it. During the following days, we will make sure to answer all of the questions that we have received. And also, we will share the recorded version of the webinar for all of you who might have joined late. And please share it with your colleagues who were not able to attend the live session today. So on behalf of everyone here, we wish you a good evening.